Antisocial personality disorder is associated with disregard for and violation of the rights of others, social impairment and offending behaviours, increased risk of mental and physical health problems, particularly substance misuse. The impact of antisocial personality disorder is generally greatest in early adulthood. Although some people recover over time, others continue to experience social and interpersonal difficulties. The cause of antisocial personality disorder is uncertain, but we know that risk factors include a history of childhood or adolescent conduct disorder, an uncontrolled, impulsive, aggressive, callous or hyperactive temperament during childhood and adolescence, with low IQ and poor educational achievement. Family factors, such as having an antisocial parent, poor supervision, abuse and violence between parents. Wider social factors, such as antisocial peer group and high levels of delinquency in school. Other mental health problems during childhood and adolescence, particularly depression, oppositional disorder and substance misuse. These risk factors often occur together, and antisocial personality disorder could be seen as the consequence of the accumulation and interaction of multiple factors through an individual's development. Criminal behaviour is central to the definition of antisocial personality disorder. Although it is often the culmination of previous long-standing difficulties, such as socio-economic, educational and family problems. However, there is more to antisocial personality disorder than criminal behaviour alone. Not everyone convicted of a criminal offence meets the criteria for ASPD, and many people with no criminal history have the diagnosis. A history of aggression, unemployment and promiscuity are more common than serious crimes among people with ASPD. The ways in which people with personality disorder, including those with ASPD, have been managed by mental health services are complicated, and service users have often been treated at the margins through A&E departments, inpatient wards and on the caseloads of the community psychiatric staff who may not have the specialist skills or time required. Greater awareness is needed to ensure early support and interventions are in place, and services need pathways between different elements of care in order to coordinate care effectively. The focus of this guideline is on healthcare services, but effective care of people with ASPD requires close working links with other services, in particular the criminal justice system. The NICE guideline contains lots of recommendations about how care can be improved, but the experts who wrote the guideline have chosen 6 areas of priority, and within these there are key recommendations that they think will have the greatest impact on care and are the most important priorities for implementation.
Hello Kirsty, I'm Pauline. I'm a new probation officer and I'm here to meet you and get to know you a little bit and find out where we're going to go from here together.
Right.
How are you feeling today?
I feel terrible and I don't even know what I'm really doing here, because no doubt it will just be another load of crap.
And we're just here to talk, just to get to know each other and to find out a way forward that's acceptable to you as well as me. Okay, can we talk about this? Have you got any social network, any friends that you can rely on and go to if you're feeling upset, stressed?
I don't really rely on anyone because I don't trust them. Because I always found out before that when you try to trust people, they always let you down, so it's pointless really.
Have you got any family at all?
Well, I was born, so obviously I've got a family, but I don't have anything to do with them. They're all useless. If it weren't for half of them, I wouldn't be in this mess anyway. They never wanted me, and I got passed around to various other people. None of them wanted me. But they're not people that I would trust. I don't want them to know anything about my business, and they're not really interested in me anyway, so...
Well, I'll be here for you anyway, Kirsty.
Really?
Really?
Mm.
Yeah. Okay, we're just here to see if there's a way forward. Well, do you have a connection with your GP at all?
But yeah, my GP is pretty good.
Should we refer to any sort of therapies or health treatment?
No, she's referred me to loads of things, but they all seem to be a bit useless. And I'm just getting fed up. I can't see the point of it. Nobody seems to be able to help me, but I'm going round and round in circles. And of course, I'm going to go back to prison again if I can't get some way of being helped. But I can't see any way forward. It's a bit helpless, hopeless.
It's one of the things I can help you with is stay out of prison.
But I do seem to spend an awful lot of time coming in and out, and then I can't really settle down when I get out because I'm only going to be out for 5 minutes and I'll be back in again.
Okay, we can look at that. Could I just ask you a little bit about your current stresses? What how can we help you stay out of prison? What can we do together?
Well, my biggest stress at the moment is that I'm likely to go back into prison, and I'm supposed to keep accommodation over my head, but that's not turning out to be too successful because they moan a bit because all my friends take drugs and so do I, and because I feel whenever I go to see anybody, nobody really gets a full picture, and a lot of people kind of get scared when they know little things about me, so it's not very helpful. But if you say you're going to support me, I suppose that'll be a bit different.
I will support you too, and we will work together. And along with this assessment, we do what's called a structured clinical assessment.
What's that?
You will go and see somebody and they will interview you, find out what your problems are and how you see them, and this can be passed on, and we can see if we can work our way through these problems and help you out. May need for other therapies as well.
Well, I've done loads of therapies before and none of them ever worked. I'm only here because I've got to stop myself going back to prison if I can.
Well, that's one of the reasons I'm here as well, Kirsty, so on that we do agree and we will work together. At some point in the future I am going to make a multi-organisational meeting which you will attend to see if we can look at some of these problems around housing, your drug abuse, and where we go forward to get you help that you really need, Kirsty.
Oh, alright, that could be a little bit different then. Yeah, alright.
Okay, thank you for your time.
Staff working with people with antisocial personality disorder should recognise that a positive and rewarding approach is more likely to be successful in engaging and retaining people in treatment. Staff should explore treatment options in an atmosphere of hope and optimism, explaining that recovery is possible and attainable. Build a trusting relationship, work in an open, engaging and non-judgmental manner, and be consistent and reliable. Under current diagnostic systems, ASPD is not formally recognised before the age of 18, but its features can manifest earlier as conduct disorder. The number of people with childhood conduct disorder who develop antisocial personality disorder as adults varies from 40 to 70% in different studies. Evidence indicates that there is considerable value in working on preventative measures with children and young people who are at risk and their families. For children with conduct disorders, group-based educational programs for parents are recommended. Where there are particular difficulties engaging with the parents or a family's needs are too complex to be met by these programs, individual-based parent training education programs are recommended. Programs should include problem solving, both for parent and in helping to train their child to solve problems, and the promotion of positive behaviour, for example through support, use of praise and reward. Cognitive problem-solving skills training should be considered for children aged 8 years and older with conduct problems if the child's family are unwilling or unable to engage with a parent training programme, or the child suffers additional factors such as callous and unemotional traits, which may reduce the likelihood of the child benefiting from parent training programmes alone. Healthcare professionals in forensic or specialist personality disorder services should consider, as part of a structured clinical assessment, routinely using a standardised measure of the severity of antisocial personality disorder, such as Psychopathy Checklist Revised, or Psychopathy Checklist Screening Version. Also, formal assessment tools such as the Historical Clinical Risk Management 20 can help to develop a risk management strategy. For people with ASPD with a history of offending behaviour who are in community and institutional care, it is worth considering group-based cognitive and behavioural interventions, for example programmes such as reasoning and rehabilitation, which are focused on reducing offending and other antisocial behaviour. For people with ASPD, including those with substance misuse problems, it is worth considering offering group-based cognitive and behavioural interventions in order to address problems such as impulsivity, interpersonal difficulties, and antisocial behaviour. For young offenders aged 17 years or younger with a history of offending behaviour who are in institutional care, group-based cognitive and behavioural interventions aimed at young offenders and that are focused on reducing offending and other antisocial behaviour are worthwhile. When providing cognitive and behavioural interventions, it is important to assess the level of risk and adjust the duration and intensity of the programme so that it is suitable for that individual, and to provide support and encouragement to help participants to attend and complete programmes, including people who are under a legal order to do so.
I think you all know who I am.
And I'm Kirsty's GP.
As I say, my main concern is keeping Kirsty out of prison. It's not the appropriate place for this client to be. She came into my care when she was homeless before. I'm aware that she's using street drugs again. She does have prescription drugs from her GP, and I was just wondering if we could help her with a way forward with Kirsty to keep her safe, really.
Well, certainly from my point of view, I'm really glad we've called this meeting today. I mean, Kirsty's been coming to see me for many years now. Often sort of several times a month, and really feel like we're at the end of our tether. I mean, I know Kirsty's clearly very troubled, but our interventions haven't worked. We've referred her to counselling.
I've just been to loads of places over the years, but no one ever fucking listens, so I don't know what I'm even doing sitting here.
I feel that we need some more help from the psychiatrist. I mean, I'm not a specialist in this area.
Well, and we would say the same in housing. I mean, Kirsty knows full well she's miles behind with her rent. There's obviously drugs and stuff going on. Your flat is not going to be there for you for much longer. It's just not going to be tenable for much longer. She's not going to be able to stay unless something changes, unless something gets done about it.
I think the problem from our point of view is, we've met with you a number of times, some of my colleagues, and have we actually got a diagnosis yet, or?
Well, the last psychiatrist you sent me to said I had antisocial personality disorder, but I don't see that I've got anything like that wrong with me. It's all you lot.
Been sort of quite disruptive when we've sort of tried to set things up for you in the past and things. I really don't see whether there's anything that we can really offer going forward from here.
So you're just going to let me go?
No, as her general practitioner, that doesn't feel good enough. I mean, I'm not a specialist in this area, and I don't know what else to do. And I feel that, if the psychiatric services are saying they can't help, and for the psychiatric services to say there's nowhere to go, I don't think that's on, actually.
Well, I think the main problem is so we've organised things before, and you've just either not turned up or you've been disruptive. There is a local day service that does run for clients, more appropriately set up for clients with personality disorder.
Why is it that whatever I've got, nobody ever deals with? I'm doing that. Fuck yourselves, a lot of you.
She's not got long left before she's going to be evicted. She's going to be on the streets from our point of view. It's going to make a difference.
So from a probation officer's point of view, she was on the streets when she came into our hands, and my concern is if she goes back on the streets, she will turn to crime.
I mean, I don't know if this is the answer or not, but she's just not going to keep her flat at this rate.
If I was willing to come along to an assessment with her just to get her settled in, and you could maintain her housing for a little while longer possibly, and try and keep her on this road to therapy, and hopefully we can get
certainly
through
we'll
this
maintain
crisis.
our support.
I'll be willing to do that.
How long is it going to be?
I think we're getting an initial assessment for the service in about 4 weeks' time. So
We might be able to hang on for a month if there's definitely something going to come of it. And if you're going
And I like
take her along,
visits
that's
between myself and the GP. We can see on a regular basis until the therapy starts, and then we get into therapy as long.
And we're going to meet again, our slot.
We meet again. Shall we say 3 months? That gives therapy
Yeah.
2 months to work.
That's
3 months review.
Okay.
okay.
Yeah.
Okay.
Right.
Thank you everyone for coming. I'll thank Kirsty later. Thank you.
Provision of services for people with antisocial personality disorder often involves significant interagency working. Therefore, services should ensure that there are clear pathways for people with antisocial personality disorder so that the most effective multi-agency care is provided. These pathways should specify the various interventions that are available at each point and enable effective communication among clinicians and organisations at all points, and provide the means to resolve differences and disagreements. Clearly agreed local criteria should also be established for the transfer of people with antisocial personality disorder between services. As far as is possible, shared objective criteria should be developed for a good and comprehensive assessment of need and risk. healthcare professionals should normally only consider admitting people with ASPD to inpatient services for crisis management, or for the treatment of other disorders which themselves require admission. This should be brief, and where possible it should be set out in a previously agreed crisis plan, which has a defined purpose and end point. The majority of people with ASPD are engaged with primary care, less with secondary services, and only a small number move with specialist services. However, the specialist services have a significant role supporting primary and secondary care services with training and consultation. Services should consider establishing multi-agency ASPD networks, where possible linked to other personality disorder networks. They can be organised at various levels: primary care trusts, local authorities, strategic health authorities or government offices. These should actively involve service users and should have a significant role in training staff across all sectors, and have resources to provide specialist support and supervision for those working in these services. They could also take a central role in the development of standards for clinical pathways, and be able to monitor the effective operation of those pathways.